Right. Do you think everybody can see my screen? And then just once again, guys, please don't be shy to ask questions, to put up your hand. Afterwards, there will definitely be time for some questions. And then for those of you that's here, we've asked Chantal and Marlou to share on the Grooteskuur and Tigerberg student groups, but obviously other students can also apply. We are looking for a new student coordinators next year. Both Marlou and Chantal is completing their 6th year, so they are moving on to internship. So if any of you are interested in applying for those positions, it's lots of fun. You'll get lots of nice exposure. You can contact Lou or you can contact Marlou or Chantal and we'll send you details. Lou, that has been shared. Has that only been shared on the groups? It hasn't been shared with the subscribers to this webinar, right? The ads.
No, but we will. So yeah, only UCT and Marty's, or well, only to Chantal and Marlou's networks or their groups.
Yes. Okay,
and
great.
then on
So we
social
can.
media was the other place we had it. But I will definitely send it onto this group afterwards.
Fantastic, fantastic. So we can definitely share it because I know we've got students joining from George, we've got students joining from Livingston. So yeah, everybody's welcome. Okay, let's get cracking. So what I would like you guys to take away from this now. What's the issue here now? Sorry. Just, ooh, yeah, it's going to be interesting. Okay, this is not working. The sharing is, hang on. Sorry, guys. Okay, so what I think is very important for you, what I want you to take away from this is I want you to remember some of the previous conversations that we've had. So yes, this is an academic talk, but at the same time, I want you to think about the skills that we spoke about when we chatted about advocacy, when we spoke about how to communicate, how to talk to a cancer patient. Because having this knowledge and having this in a textbook or having this in your head is a good start, but it's not good enough. Because really what it is about, how you take this information and not just integrate it for yourself, for your own knowledge, for your own practice, in order to be a good doctor, but also how you actually take this information, synthesize it in a way that you can communicate it to a patient in a way that they can understand and that they can feel empowered by it. Okay, so obvious statistic, we know that breast cancer is by far the most commonly diagnosed cancer. That goes for both genders across all cancers. Breast cancer is the most common diagnosed cancer according to the WHO. The statistics at the moment is 1 in 8. It's veering towards 1 in 7 women in their lifetime will face a breast cancer diagnosis. So it's staggering. It is, you will see a lot of this disease in your careers. Okay. The most important thing when I speak to students is always to remember that everybody wants to know, am I at risk? Am I at risk? And by understanding what we understand of risk factors, you can educate patients. So even if they come to you not necessarily for a breast assessment, but you see them in the gynae clinic, or it's just somebody that comes for her hypertension medication or whatever, to take the opportunity to educate patients about what could potentially put them at risk. And at the same time, communicating that this is what we understand of the disease, but that this clearly is not the full picture. It's very, very hard at any point to pinpoint one single thing that caused a patient's breast cancer. And while that can be very, very frustrating, in some regard, it can also be reassuring to a patient, as in that they did not necessarily do something wrong. It's not their fault. And very often, breast cancer A breast cancer diagnosis it's like the Swiss cheese lining up, right? It's a layer upon layer of small things that happen that a woman can be exposed to that will increase her overall risk. So genetics, obviously all of you know of the BRCA1 and BRCA2 genes. There are about 64 other genes, maybe more now already. When we do a panel, we test for about 86 genes that is associated with the increased breast cancer risk. Not all of these genes have the same amount of risk connected to it. So by far, your highest risk genes are your BRCA1 and BRCA2 genes, and then also your P10 and your P53 mutations. Other ones that you should maybe know about is your CHEK2 gene mutations and your PALB3 mutations. So those are the genes that carry by far the most significant risk. But it's very important to understand and to explain to your patient that only about 5 to 10% of all breast cancers would we be able to identify a genetic mutation. The rest, we do not know. And this is where the sort of layering of other risk factors come at play. So, of course, we look at family history, even though we cannot pinpoint a genetic mutation. It is very important to take a thorough family history and look at all the cancers in the family, because that will still, when you do some of your online risk calculators. So I don't know if you guys have been exposed to or if you've ever heard about the online risk calculators. One that I like using and that's very often used, I know at Grooteskier and Tygerberg Hospital, is called the IBIS risk calculator, where you can basically slot in, and then there's also the CAN risk, CAN risk online calculator, where you can slot in a patient's not only their family history but also other history like their menarche, the number of children they've had, exogenous hormone exposure, etc. And it literally calculates an estimate of a current risk and a lifetime risk for breast cancer. So look at the patient in the family as a whole, not just in terms of breast cancer, but of other cancers. We know colorectal cancers, prostate cancer, some of your pancreatic cancers, melanomas, all of those cancers. When you start seeing a pattern in a family, when you start seeing, but there's quite a few family members affected by these cancers, that must also trigger a potential genetics referral of a patient, because all of those cancers can be linked to any one of those genes that I've mentioned: BRCA1, BRCA2, PALB3, CHEK, your P10, P53 mutations, all of them are interlinked. Then, of course, with breast cancer, as all of you are aware, hormones are super important. So everything that kind of plays into a woman's endogenous, meaning her own estrogen, progesterone that she produces, that exposure, as well as exogenous hormone exposure. So that is hormones that she's actually taking in tablet form, that it plays a role. So our estrogen window is basically from when a patient has her first period, her menarche, until she goes into menopause. So that is her natural exposure to her own estrogen. And the longer that window is, the higher the risk for the development of breast cancer. Age at first birth. So the earlier a woman has children in her life, the more protective it is against breast cancer. If a woman does not have any children or she's had children later on in life, that would be considered a minor risk factor for breast cancer. Breastfeeding is considered protective against breast cancer, but it's not a guarantee that you won't get it. On the contrary, we see in our population, strangely enough, that breast cancer does not offer such a big protective factor as is reported in first world literature. And then, of course, there is your exogenous hormones, which is oral contraceptive and hormone replacement therapy, those can become very contentious issues because, both of those modalities have absolute benefit and there's a place for them. And just because there is a small associated risk with breast cancer does not mean that you should not prescribe these drugs to your patients. It's about understanding your patient's risk and explaining to them, listen, we are going to put in a Mirena for you, but we're not going to put in more than 2 or 3 because we know after 2 or 3 Mirenas, risk does increase. When you take oral contraceptive, take a break. Every 5 years, reevaluate your contraceptive plan, switch it up. Same with hormone replacement therapy. It is incredible for bone density protection, for cardiac health protection. But if your patient has a massively strong family history, you probably should not prescribe HRT to that patient. And all patients that is on hormone replacement therapy should be enrolled in some form of breast screening, and that HRT should be re-evaluated on a regular basis so that the patient can be on the lowest effective dose for them for the shortest period as possible. And then, of course, there's lifestyle, diet, exercise, alcohol, sleep pattern. So we now know that night shift workers, people with a very disrupted sleep pattern may be at risk for cancers, not just breast cancer, because that is the body's natural way of when the immune system is really working at its best. And stress. So those are the things that you can educate your patient about and that you should also ask your patient about. I always ask them in terms of stress, what's happened in your life the last 5 years? Divorce, death of a loved one, a move, any major stresses, note that, and with the understanding that you're not going to communicate to your patient that is why you are getting breast cancer. It is the perfect storm. It's 90% of the time, it is many of these risk factors lining up in an individual and a cancer diagnosis happens. Okay, so I think what makes it incredibly difficult for patients are that there are so many opinions out there. Their brothers, mothers, whatever, auntie, neighbor, everybody is going to have a cancer story, and they're going to tell them horrible things that happen to everybody around them with cancer. And to immediately ground a patient to know that, to give them the sense that you understand this topic, that you are willing to answer their questions, that you can explain it in a clear and concise way to them, and that they must develop selective listening and selective hearing. People mean well, but honestly, people are going to drive you crazy with all the opinions that they have. So in terms of the assessment of a patient presenting to you in the clinic with a breast lump, always remember, if anybody asks you or an examiner, gold standard is the triple assessment of the patient. So it's a clinical assessment that combines both your history as well as your clinical examination. And when you take your history, remember to take your history in such a way that you can already risk stratify your patient. So what I mean by that is take your history to include these risk factors that we've just assessed. So when an examiner asks, you're going to say, I'm going to do a clinical assessment that's going to include a full medical history, including questions that would allow me to risk stratify my patient, as well as a thorough clinical examination. Clinical examination, of course, a brief systemic examination, but when we look at the breast examination, remember that the breast examination includes examination of the axilla, as well as the infra and supraclavicular areas and the cervical nodes as well. Tell the examiner what you see. Is there any skin changes? Is there any nipple changes, nipple retraction, nipple discharges? Is there a visible palpable lump? Is there architectural distortion, deformity? Is there maybe a podorange? Palpate. What do you feel? Is it a fixed lump? Is it a mobile lump? Is it smooth-walled? Is it irregularly shaped? Is it warm to touch? Is it cold? Is it painful? Is it painless? And then absolutely 100% remember to comment on your nodes, axillary, supraclavicular, cervical, okay, and both breasts, right? Then, after our clinical assessment, in the ideal scenario, we would like to get imaging, which can be one of three modalities. It can be either an ultrasound, a mammogram, or a breast MRI. In the ideal world, we would like to combine an ultrasound with every mammogram that we do. In essence, general rule of thumb is that the denser the breast tissue, the more useful the ultrasound, okay, and the less useful the mammogram. Okay, so your type C, type D, very dense breast definitely would need the adjunct of an ultrasound in order to make a proper assessment of the breast. That is also why we say in general, patients younger than 40, you can do an ultrasound for. Patients over the age of 40, you can do a mammogram plus minus an ultrasound for. Age is it's a very crude way of dividing these things, because you can get older patients with extremely dense breast tissue and you can get very young patients with very fatty breast tissue. So when an examiner asks you about it, say, the modalities are predominantly ultrasound or mammography. Sometimes we use age as cutoff, where a younger patient, we would prefer to do an ultrasound. In an older patient, we would prefer to do a mammogram. But really what we are looking for is in our denser breast tissues, an ultrasound would be more useful. And in more fatty, more heterogeneous breast tissue, a mammogram would be more useful. Breast MRI is really only kept for our high-risk patients, so young patients with a known genetic mutation, we would definitely use breast MRI with. And then in the private sector and in the ideal world, where we have a patient with, for instance, DCIS, a very small area on mammography, and we want to make sure that it is actually safe to perform breast conserving surgery on a patient, we would request a breast MRI. In many of our lobular cancers, if we want to do breast conserving surgery, we would consider doing a breast MRI. Okay, so breast MRI is not the first thing in an exam that you're going to mention. You're going to mention ultrasound, mammography, and then you're going to say in select patients with select criteria, a breast MRI can be extremely useful. And then, of course, the last part of the triple assessment would be the tissue diagnosis. Somebody needs to look under a microscope and see what's going on with this breast lump. So, takeaway message that I want you guys to remember today is any patient over the age of 25 that presents with a palpable breast lump needs a biopsy. I don't care if it looks like a fibroadenoma on ultrasound. If the patient's 25, you can feel a lump, you put a needle in it. It's that simple. Okay, it's incredibly important because this is how breast cancers in young patients gets missed. The only patients that we will have some tolerance for only imaging follow-up would be in your teenagers, so patients younger than 20 to 25, case-to-case basis, but I always err on the side of rather getting a tissue diagnosis. Over the age of 25, absolute, definite, you need to put a needle in that lump. Okay. Different types of biopsies that we can do. Fine needle aspiration biopsies that will give us cytology, where we just get information about the cells. So is it benign malignant cells? But more importantly, and definitely what we want ideally, is a core needle biopsy where we can look at the histology of the tumor. All right. The reason being is because it gives us not just a positive or a negative diagnosis. It's not just, yes, it's breast cancer. No, it's not breast cancer. If it is breast cancer, it tells us, that histology tells us so much about the biological personality of the cancer. And that is really what we want to understand in order to plan the patient's treatment. Okay, so when we look at the patient's breast cancer journey, in essence, the general trajectory is going to be, first, we need to name the cancer. Then we need to stage the cancer. Then it needs to be discussed in a multidisciplinary team. That is essential. And then we progress to treatment. And eventually we want to get the patient to survivorship, which is it's a whole phase of the treatment journey in itself. Okay, so naming the cancer. That's where our histology becomes so important. So you will see in your textbooks, I'm sure you are well aware, we get ductal carcinoma, we get lobular carcinoma, mucinous carcinoma, papillary carcinomas. If we look at the histological subtypes of cancers, there are many, okay? But does it matter? Nah, not really, okay? We don't care that much. What we care about is the molecular subtype of the cancer. So this molecular subtype, luminal A, luminal B, HER2 overexpressed, basal-like, can present in any histological subtype. So ductal, lobular, mucinous, papillary, doesn't matter. You can find these molecular subtypes. And this molecular subtypes, the cancer biology, really determines the cancer personality. And this is what's going to guide your treatment. So so it's called the St. Gallen's classification, molecular classification of breast cancer. Essentially, we have our luminal A breast cancers, which is our very hormone positive cancers, estrogen and progesterone strongly positive. It does not express HER2, which is a growth factor, and the Ki-67, which is essentially a marker of cell division. So the cell division rate, the cell turnover rate of the cancer, how quickly it turns over, is low. It's less than 14%. Luminal B cancers, so you get luminal B like HER2 negative and luminal B like HER2 positive. And basically what it means is it can either be hormone positive, ER, PR positive, with a cell division rate of more than 14%. Okay, and then it can either express HER2 or not express HER2. All right. Then our HER2 overexpressed cancers, so that is ER negative, PR negative, HER2 strongly positive, and usually these cancers will have a very high cell division rate. And then our basal-like breast cancers, which is our real nasties, triple negative, ER negative, PR negative, HER2 negative, very high Ki-67%, usually well above 50%. Those are the ones that, those are the big subtypes that we're looking at. So how I explain this to patients is, if you look at a family, you get botas from Benoni and you get botas from Brakpan. Or in Cape Town, you get botas from Bellville and you get botas from Kuils River. They're not the same botas. You get different botas. Okay, so every family is different, even though they're both called breast cancer. Different family, different story. And within each family, you have different faces, different personalities. So you get your not so nice personalities, which is usually your luminal Bs. They are sneaky. They can be not so aggressive, but they can be sometimes tricky to treat. Your luminal A cancers are usually super nice, super lazy, super friendly. Kind of, if you're going to have a cancer, probably a luminal A is not a bad one to have. Then your triple negatives, creepy, crazy, shitty, terrible personalities. And then your really mean, sort of also HER2 positive breast cancer. So it's just understanding and helping the patient understand that your treatment is not going to look like the next patient's treatment, because each personality has its own treatment. Okay. The timing of the treatment, as well as the type of the treatment and the combination of the treatment, will differ depending on this personality of the cancer. All right. So combinations of treatments. So the basket of treatments that we can pick from is basically a combination of surgery, endocrine therapy plus minus ovarian suppression. So endocrine therapy meaning hormone blocking therapy. So we block the estrogen, block the progesterone receptors. Chemotherapy, biologicals or immune therapy, and radiotherapy. And this, of course, then we also want to include our lifestyle changes, our psychological support, physio support, family support, all of that also forms part of the treatment basket. But just in terms of the different personalities, this is kind of the basket that we will look at. Okay. We need to stage the patient. So in terms of staging, usually where does breast cancer like to go? Breast cancer loves the bones, the brain, the lungs, and the liver. All right. In the ideal setting in private practice, we usually do a CT chest, abdomen, and an MRI skeletal survey for all our patients. In the state sector, we have to be very, cognizant of our resources. So we would only do a chest x-ray, a liver ultrasound, and then in our higher stage patients, so patients with bigger tumors or palpable lymph nodes, we will rather do a bone scan plus a CT scan or an MRI skeletal survey. But that will then determine whether, whether there is or exclude that there is metastatic disease present. And then we go to the MDT meeting, and at the MDT, there should be a surgeon, a plastic surgeon, an oncologist, a radiologist, a pathologist, a geneticist, ideally a psychologist, a social worker. Everybody needs to be present, and where we go through the patient's case from the clinical presentation that gets presented right through to the radiology, the staging, and everything. So for example, this is just how a case study would look and how we would do it. So let's say we've got a 34-year-old female patient, grab 1, para 1. She presented with a left breast lump, and on imaging, it was a BI-RADS 5. Okay, so BI-RADS 5, guys, that is the classification system that we use for both ultrasound and mammography. BI-RADS 1 being a completely normal breast, BI-RADS 5 being highly suspicious for malignancy, and a lot can happen in between. If we do more of these lectures and you are interested, we can sort of do a deep dive into the pathology. We can do a deep dive into the radiology if that is what you're interested in. But for now, I just want to give you like a basic overview, the basics that you need to know. Okay, clinically a T1N1, so small lump, less than 2 centimeters, the T&M classification system. T1 is a 0 to 2 centimeters, 2 to 5 centimeters is a T2, T3 is bigger than 5 centimeters, T4 is any involvement of skin, muscle, or adjacent structures. And then nodes in 1, axillary node, in 2 would also be axillary node but matted and quite fixated, and in 3 would include your supraclavicular area. Okay. Right, so somebody's radio is on. Okay, right. So the patient had her biopsy and it came back as an infiltrating ductal carcinoma, ER8, PR7, so it's very strongly estrogen positive, very strongly progesterone positive. HER2 is 1+, that essentially means it is HER2 negative, so it doesn't have the growth factor. And the Ki67 is quite high, so it's 60%. So if we have to classify it into our little table, this will be a luminal B HER2 negative breast cancer. I can quickly go and remind you there. We look at that. So it is Ki is above 14%. It's on the higher end. So, but anything above 14% will immediately put the patient in the luminal B category, and it's ER positive, PR positive, and HER2 negative. So that is what that patient has. Okay, so remember our conversation and our talk about breaking bad news. Counsel the patient and the family. Make sure you've done your metastatic workup. Make sure you've referred, you've liaised with all your colleagues that needs to be involved in this patient. At the MDT, we're going to look at the radiology. We're going to look at the initial imaging. We're going to decide if the patient, she's 34 years old, if she's only had an ultrasound of her left breast, we're going to say we need both her breasts imaged. We'll probably do a mammogram, doesn't matter her age, and we'll make sure we image both her breasts. If she's got exceptionally dense breast tissue, we may even say due to her age, we probably need we could do an MRI for her. Pathology, we will review the results, make sure that everybody is happy. We'll classify it, like I say, a luminal B. Genetics, looking at a family history, we will say, should we test in this patient? Yes, absolutely, purely because of her age. It's very young to get a breast cancer, so she should be referred to genetics. And we'll talk about surgery. When we will do the surgery, whether we will do breast conserving surgery or radical surgery, meaning a mastectomy, whether we would operate on both her breasts or just one of her breasts, unilateral versus bilateral, whether she's a candidate for skin or nipple-sparing mastectomy, whether we can do reconstruction, what we're going to do with the axilla. So in her case, she's got a positive node. So, are we going to do a sentinel node? Are we going to do a clearance? Does she need a chemo port? Will she need chemotherapy? So those are the intricacies around the surgical decision-making that has to happen. And all of this will depend on the patient as a whole, what we see on her imaging, what's happening in the breast. Is it one area that's involved, more than one area that's involved, the size of the tumor, the size of her breast, her genetic risk factors, whether we will do one breast, both breasts, whether she's a good candidate for reconstruction, etc. Plastic surgery will obviously give an opinion about reconstruction, symmetry. Gynae, also very important, especially in the young patient that's hormone positive. It gets intricate because what about her fertility? Should we suppress her ovaries because her ovaries are pumping out estrogen, it's pumping out progesterone, and we need to switch that off. There's ways and means in which we can do it. We can either do it chemically or we can actually go and remove the ovaries, although if possible, we prefer not to do that. And then oncology needs to say, should we be thinking about new adjuvant chemotherapy for this patient? New adjuvant meaning before surgery. Adjuvant endocrine therapy after surgery. Are we going to continue her on a hormone blocker? And yes, in this case, we would. Would we do chemo? Would we do radiation? So quickly, if I look at this patient, the fact that she's got nodal disease, the fact that she's got a very high Ki-67, this could potentially be a patient that we would start with new adjuvant chemotherapy. So we would start with the chemotherapy, followed by surgery, possibly bilateral skin and nipple sparing mastectomies because it's a small tumor with reconstruction. After the new adjuvant chemotherapy, we could potentially do a sentinel node for her because she only has one node positive, but that needs to be discussed because she may need a clearance as well. Surgery will then be followed by endocrine therapy for 5 years where we block her hormones. And then if the nodes remain positive after chemotherapy, she will also need radiation. Sorry, that's cut off there. And then, of course, she needs to be seen by a nutritionist or a dietitian if possible. She needs psychological support, counselor, social worker, and if it is available, a support group. Okay, so deciding on treatment. So I think this case study has basically, if you have to draw like a little flow diagram for yourself after the diagnosis. So if you take breast lump, you draw a line, you say, okay, diagnosis, treatment. Under diagnosis, we've got triple assessment being clinical diagnosis, imaging, biopsy. Then from biopsy, we go, okay, we need to name the cancer, we need to stage the cancer. From there, we go treatment. Okay, treatment divided into surgery, oncology being divided into chemotherapy or endocrine therapy or radiotherapy. Surgery can be divided into surgery to the breast, surgery to the axilla, and we can do reconstruction in both scenarios. So with a mastectomy, removing all the breast tissue, we can do a contralateral reduction or symmetralization. We can do a lumpectomy, just removing part of the breast. If we remove a large part of the breast in a large with a lot of breast tissue, we can do a contralateral reduction again for symmetry. So reconstruction is not as narrow as you only do it in a patient that gets bilateral mastectomies with bilateral implants. There's many, many nuances around this. And then your axilla, you're either going to do a clearance or you're going to do a sentinel node. Reconstruction can be immediate, can be delayed, it can be the patient's own tissue, or it can be an implant. Okay, so there's a lot of nuances, and as I'm talking, I'm realizing this must be very overwhelming to all of you, and we're probably going to have to do in our next webinars. What we'll do is we'll break it down, and we'll do one webinar just around the surgery, and we'll do one webinar just around the oncology, just to get you guys to have a greater, a better grip on all of it, because it does get quite nuanced. Okay, oncology. So chemotherapy, you can either give it before surgery, which is neoadjuvant, or after surgery, which is adjuvant. You get different types of chemotherapy. The most common ones is the adriamycin-based or the red devil chemotherapy that the patients start with for 4 cycles, followed by the taxanes for 12 cycles if you do dose dense therapy, or an additional 4 cycles if you don't do dense therapy. And then we can also use modalities that we call OncoDX or MammaPrint to help us decide whether chemotherapy would be beneficial for the patient or not. That is essentially testing the tumor against different therapies and seeing what response we get, whether endocrine therapy is enough or whether we need to add some of our chemotherapy drugs to get an optimal outcome for the patient. That is unfortunately only available in private practice. Endocrine therapy can also be done either before or after surgery, and you get different types. So for your young patients, you look at your SERMs, and your older patients, you look at your aromatase inhibitors. So selective estrogen receptor modulators, your SERMs, and your aromatase inhibitors. So that's tamoxifen is the name that you may know. So that's more your premenopausal patients, and arimidex being an example of aromatase inhibitor for your postmenopausal patients. Radiotherapy, you can get short course, long course radiotherapy. There's different fields that you can include. You can either include the whole breast radiation, or you can just focus on the axilla or the always including the supraclavicular area. And then our biologicals or our immune therapy. This is really where I think the future lies. It's made a huge difference, especially in our HER2 positive breast cancers. So you may be familiar with Herceptin or trastuzumab, which is a biological that specifically targets the HER2 receptor in breast cancer and has really, really, really had a positive impact on those patients' outcome and survival. And then the thing that everybody always forgets about is survivorship and follow-up for these patients that can get very, very intense, where patients, and this is where I think, again, this is a webinar by itself, is working with the patient in terms of how they cope, how their diagnosis and their treatment has actually impacted on their sexual health and relationships. Remember, so for instance, our patient that we've just discussed is 34 years old, and essentially, as part of our treatment, we are going to put her into premature menopause. That premature menopause is going to have a huge impact on her sexual health. She will suddenly struggle with mood changes, hot flashes, vaginal dryness. She will not be able to fall pregnant. It will have an impact long-term on her bone health, on her cardiac health. So it's got the ripple effect of the treatment in itself has got a major impact on these patients' long-term life experience, medical risk factors, etc. And it needs to be recognized and it needs to be proactively managed. Support groups, the ripple effect of it's not just the patient that's impacted, but it's the whole family, it's the whole environment, that's actually dealing with everything that this patient is being put through. the side effects of the treatment, the psychology of dread. It's a very, very real thing where patients are actually fine during their treatment. They're coping, they're positive, and then as soon as you tell them, great, I'm going to discharge you, you are in remission, the patient goes into an absolute tailspin because they're like, I'm just waiting for this to come back. Is it coming back? When is it going to come back? They hate coming for their screenings. They hate coming for their, all of that. It's terror, really, that grips them. And it's proactively managing and supporting them in that. So just to bring us back after all the academics, which I realize is very freaking overwhelming, and we really have to break this down for you further. But for both you and for the patient, is to bring them back to the space where they can breathe, to take a breath, to remember what we talk about, that we're not just talking about cure, that we're talking about healing, that we're talking about wholeness, awakeness, and that we speak to the patient around this disease in a way that's relatable, that's understandable, and that really brings down this sort of message of healing, of support, grounding them, and just bringing down that sympathetic healing system. So always keeping in mind the 5 pillars of healing: the socio-emotional support of the patient, optimizing the cellular environment. So talk to the patient about smoking and diet and exercise and sleep and stress. There's the medicine, which is obviously all the complicated things that we do. Very important to have the honest but very gentle conversation of the patient to get your house in order. Make provisions, plan ahead. How's your hospitalization going to look? What's going to happen if you're not feeling well? Do you have a support structure in place? And then talk about the patient, about their psycho-spiritual space, what help they need, what support they need, where they're at with that. And if you can optimize these 5 pillars, then we can really work not just towards cure, but also towards healing. All right. And to remind you of the integrative medicine principles that, I think we all have an obligation to sort of weave into all the very academic and very allopathic medical things that we do, is to remember mindful eating, allowing the patient or encouraging the patient to take control of their own health, to follow and to trust their intuition, to use supplements that you are aware of and that you can vouch for, releasing suppressed emotions, increasing positive emotions, embracing social support, deepening their spiritual connection, having a strongly reason for living, and not to ultimately miss the potential gift that this diagnosis can actually bring. So, yeah, that is a mouthful. Question time. I'm sure there's a lot. Yeah. Great. Obviously, we'll make the slide available on the website so you can go back just to refresh your memory. But I think this will give you, like I say, this allows you to draw a nice flow diagram for yourself in terms of how you need to think about breast cancer, look at it, and what is the main, what I say, the key points, I don't know what to say. The main things that you need to be able to tick in order to put together the puzzle of a breast cancer diagnosis and put together the puzzle of treatment. Is there anybody that's got a question for me? Maybe just by a show of hands, would you guys be interested in, say, another 2 lectures, one just focusing on surgery and the other one just focusing on oncological treatment modalities? Okay, there's hands coming up. Okay. Okay, good. Okay, so that's a yes. We'll do that then. All right. There is, okay, any questions at this point? Anything, I know it's been a lot, but is there anything that stand out for you that's like, really, this is super confusing? Please just go back to that we need to go over again. There is no such thing as a stupid question. So please, 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 please feel free to ask. Okay. Well, hopefully it wasn't that confusing then. Lou, do you have any comments from your side?
No, I'm good. Thanks, Liana. I think just that the recording will be available, so please share it with your network and your colleagues.
Yes, and then I think this is like the introduction. Just talking, when you talk through this every single day, you kind of forget how overwhelming it can be. And just talking you through this now, I realized that literally every slide that I showed you, we can have a whole lecture just on that. So what I'll do is I'll chat with Lou, I'll chat with Marlu and Chantal. We can see this was supposed to be our last webinar for the year, but maybe we can squeeze in one other one and we can focus on just the surgery, and then maybe early next year we can focus just on the oncology, and then we can break it down, maybe just do another one on reconstruction, survivorship. We can break it down for you. I think it may be easier and it may be more useful, and then we can bring in some of our other topics while we discuss that. Would that work for you? Okay, it looks like it. All right. Peoples, thank you very much for your attention and for attending. I really appreciate it. I sincerely hope it was a little bit helpful. Yeah, if there's anything in particular, you're welcome to pop an email. If there's something that you need to find out now, something that's not clear, that you don't understand, please let us know. And otherwise, we'll make a plan and we'll do a further deep dive. But hopefully this has given you a little bit clearer sense of how to go about patient presenting with a breast lump, the things you need to think about, and how you can, the different pieces that you need to put together in order to build your treatment puzzle. Okay. Have a lovely evening, everybody. Bye-bye.
Thank you so much.
Pleasure, pleasure. Enjoy.
Thank you so much,
Bye.
Doctor.
Bye-bye.
Hi, Luann. Would you still like to have a chat now at
Yes.
the end?
Yes.
I'm going to turn on my camera.
She's left. Let me just quickly find her. There you are. Medina. Let me just see if this person, I'm just going to remove them. There we go. Let me just get Liana back in.
No problem.
I'm assuming a lot of the new names I didn't know was from your side. Did you forward it on?
I don't think so.
Oh, okay.
My class is it's quite small, and there's a lot of people that like work during the holidays and stuff like that. So
Okay.
yeah.
No, because we had a sudden surge of like 30 extra people randomly today. So I thought, or earlier, it must have happened over the weekend or whatever. And then when I looked and I was like, geez, I wonder if it was you guys. But then actually, now that you mentioned it, I think a lot of the email addresses were at Sun. So it was probably Stellenbosch.
Stellenbosch, yeah.
Yeah, now she's gone. Let me just see if she's. Let's try and find her quick. She's coming.
Oh, shame. Okay.
We can chat just now. Yeah, so I think what I was quite interested just to understand your setup, because we obviously have Livingston Hospital, and we're quite active there. I think they're our second biggest site in terms of numbers. And we have quite solid student representation at Steigerberg and Groote Schuur because of the academic setup. But I mean, it doesn't mean we can't have something similar there. So when you reached out, we were quite perplexed. We didn't realize that that there was a student setup at Livingston. Well, I definitely didn't. Let me just actually stop this recording because we don't.
Sorry, completely forgot. Sorry, Rob.